I tend to use Elaine Halek's nice and very well-known study on the narrow window of vitamin K antagonists used for oral anticoagulation, and our other speakers have talked about it. Keith just mentioned it a moment ago. With this metaphor here, it's like a tightrope walker. You know, you can actually try to stay here in the middle of the field, because if you go too much to the left, you decrease your intensity of anticoagulation, you will fall off or your patient will fall off because of a high stroke risk. If you go too much to the right, you'll fall off because of a bleeding risk. Now, of course, and we just heard that from Keith, NOACs have changed that a little bit. They made it much broader, but it's still, it's not a tightrope walking act, but you can still fall off the precipice here on the left side with some strokes, or on the right side with some bleeding if you do not respect the window. Now then, we also heard that, of course, oral anticoagulation is not possible with all patients. In this pretty large study, about 13% of patients just cannot have oral anticoagulation. Of course, this was vitamin K antagonists, so it may be a little bit fewer with NOACs, but there are also contraindications to NOACs. And then also we heard from Bernie Gersh at the beginning, people just discontinue oral anticoagulation. They're even supposed to be on. We don't even know that they're not on, but they just are not on because they continue. We know that from the randomized trials, and above all from a just field study in Sweden, that actually more than 50% at some point in time just decide to stop, for a reason or for no reason. In the randomized trials, which were of course selected patients, more controlled, you see in both arms with NOACs and with warfarin the discontinuation rate somewhere between 15 and maybe up to 30% in the ENGAGE trial with the doxaban. So not everybody who could take anticoagulation or NOAC is taking it. And then we've had all this history with anticoagulation. We've come a long way, and we've had some good success. If you take no anticoagulation in atrial fibrillation at a risk of 10, we know that aspirin alone is not ineffective. Now in the European Society of Cardiology, it's advocated not to use aspirin for anticoagulation in atrial fibrillation because we have better things. It's not because it's completely ineffective. It actually has a 22% reduction of the stroke rate, but that's not good enough because we have better things. Combining it with another thienopyridine, for instance, it has an additional 28% reduction, and the overall reduction is already quite significant, but it's still not recommended to use this because we have even better things, because we had vitamin K antagonists for 50 years, where you have an overall 60% reduction, which is certainly has been the gold standard for a long time, and now we have those NOACs, which give you an even higher reduction, gaining a little bit on top of the warfarin gold standard. But even if you take the best study available here, and you still have some remaining risk here of 24%. Now we've learned from Bernie and from Jeroen that there are other factors than just mechanical things. So just closing the left atrial appendage, which is my talk, will not take away those 24%, even if you'd combine it with oral anticoagulation, which is another issue that is rarely talked about, combining mechanical approach to medical approach. It will still not be zero because there are other factors in the patient determining whether they will have a stroke with atrial fibrillation. But let me now turn to left atrial appendage closure. Why does anybody even think that it's going to work? That is based on huge reports, huge patient cohorts in reports using TEE, using surgery, using autopsy. What they found is that in patients with non-rheumatic atrial fibrillation, which basically is rheumatic mitral valve disease, something still may be quite common here in India, not so common in Europe, but all the other atrial fibrillations are so-called non-valvular atrial fibrillation. So if you have aortic stenosis atrial fibrillation, it's a non-valvular atrial fibrillation. And in those apparently 17% of patients will have a clot if they are not anticoagulated. Now, if you look at where those clots are found, you can see that 16% of the 17%, that is 94 relative percent, are in the left atrial appendage, and only 1% is in somewhere else in the left atrium. That's a bit different with rheumatic mitral valve disease, but I'm not talking about that. So imagine taking out the left atrial appendage, you'll have this situation, you'll have a remaining risk of 1%, and that's not worth anticoagulation, because, have you heard, anticoagulation has a bleeding risk which is larger than what you prevent here. So there is no need, based on these studies, to have oral anticoagulation if the patient has no LAA, period. And this is one of these more caricature left atrial appendage clot. Of course, that's quite rare that it's so big, but more common, it's something like this. And this is even out, I think, out of an Indian report, which is quite telling, because what they did a TEE, and the patient then went on to have a stroke 4 hours later, and they looked carefully at the TE where they had discovered a clot in the left atrial appendage, and found out that they actually had witnessed the embolization of the clot during the TE. So here you see the clot in the LAA. A little later it has moved more to the orifice, and then it's on the way out, and a little while later it's gone. The patient took 4 hours to develop the stroke because the clot probably broke up somewhere at the bifurcation first, and it took an hour or two before it finally occluded a brain artery. So this is clearly a fact that it happens, nobody doubts it. Most commonly, probably, you have something like this here. You have this clot in the left atrial appendage, and little pieces are breaking off. This is probably the most common reason for an embolic stroke in atrial fibrillation. Now, it was Michael Lesch, an electrophysiologist, who, while he was doing left atrial ablation in late part of the last millennium, he thought, why not, while I'm there, just to putting a plug into the left atrial appendage and taking this risk out, because most of the patients will have, again, atrial fibrillation even after my ablation therapy. He knew that already. And the first device he developed and first implanted with Horst Sievert in Frankfurt in 2001 was the Plateau device, percutaneous left atrial appendage clot occluder. So that's the name of the Plateau. And we also used it in a few cases, but I thought it was quite a complicated procedure, bulky equipment. So I remembered that putting Amplatzer devices for closing ASDs, sometimes the left disc would get stuck in the left atrial appendage because I opened it up a bit too far away from the septum, and I had to kind of pull it out of the left atrial appendage to put it on the septum. So I said, why not leaving this thing in there and clogging the left atrial appendage with an ASD device, because it seemed to actually be a much simpler technique. And same year, a little later, the Watchman, a dedicated left atrial appendage occluder device, was developed in the United States and first implanted also in Germany at the end of 2002. The Plateau device, as we know, has gone out of business. A little later, a Greek physician, pediatric cardiologist, Eleftherios Sideris, came up with the LAA transcatheter patch. They all have CE approval now and are available, the free market in Europe. And then we continue to develop this non-dedicated Amplatzer system for LAA occlusion to this now dedicated, called first ACP and then Amulet. And finally, the last kid on the block is the Wavecrest, which is also available on the market now for LAA closure. This is the principle that we developed in Bern, which I call the pacifier principle, because we're not only putting a plug into the LAA like the Watchman or the Coherix, but since it was derived from an ASD closure device with two discs, we actually left the outside disc on the device, thinking that it nicely occluded the entrance, as you can see here on the right side. And it's not unlike, the pacifier plate in front of the toddler's mouth. That's why I'm calling it the pacifier principle. Here you see a late TE view of this with the plug in the LAA and the pacifier plate, or the disc, which initially was the right atrial disc in the ASD closure device on the right side. Here you see a fluoroscopic picture. And this was the world's first patient who got an LAA closed as like doing PCI, with local anesthesia, no echo guidance, just a catheter putting this device in. It actually took less than 15 minutes. It was a very simple case. He was a butcher in June 15, 2002. And as a butcher, he had atrial fibrillation and he could not work with anticoagulation because every time he cut himself, he had to stop working for 2 hours before the bleeding stopped. So this was the indication for closing his LAA, and it's been now 14 years out, and he is retired now, but he has never taken any anticoagulation again since. He's of course still in atrial fibrillation and had a very good outcome and was very pleased with this world's first here treatment, which for him was no big deal because it was actually even an outpatient procedure as the first procedure in the world. Since we've seen that there are some difficulties, it's not always a slam dunk. It's not as easy as it appeared with this first case. This is now with an ACP, and also, like Jeroen, some nice pictures, although we don't use it in the cath lab just for simplification of the procedure, but this is a follow-up in a patient who did have an LAA closed with an ACP, went 28 millimeter ACP. Then 4 weeks later, she was also coming in for a TAVI, for a percutaneous valve implantation, and in the protocol they did a CT before that TAVI, and this is how this device looked in the CT. You see that now the LAA has taken the shape of the ACP. If you see that he also got a PFO closure, this is the PFO device, because we went through the PFO closing LAA on the way out. We reloaded our sheet and also closed the PFO. And you see, like this ACP now clearly shows, and the LAA is completely occluded, having taken the shape of the ACP device, basically. Now this is the technique. First, of course, you need a transeptal puncture unless there is a PFO. If there is a PFO, we go through the PFO and close it on the way out. If there is an ASD, which is quite rare, we go through the ASD and close it on the way out. But usually you don't have either of them. So the first is the transeptal puncture. We have no echo doing that, so we use an LAA projection. We inject a little dye through the tip of the needle, so staining the septum, so we know exactly where we're puncturing. Here we're right at the border of the septum primum and the septum secundum, which is the thick part here is the septum secundum, and the thin part is the septum primum. A little higher, usually you'd like to puncture a little lower to have a straight shot up to the LAA, which is up here. Then the next thing, over a stiff wire, which we keep in the left atrium. Others recommend to go into a pulmonary vein, but staying in the left atrium is very nice. You go in with this big sheet. It takes up to 14 French sheath for these big devices. And you can see, having stained the septum before, is quite nice because it still shows you where the septum is for the rest of the procedure. The dye will probably go away within 15 or 20 minutes, but for 20 minutes at least you see where it is. Next thing is you'll find with this nicely double curved sheet, usually the LAA quite easily. You do this injection to size your device. There are, with the Amplatz technique, about 8 different sizes, maybe too many. With the Watchman disease, there are 4 sizes that you can pick off. And you see here that quite nicely seen. The next thing is to implant the device. So you first push out the low part, which has some hooks. to prevent embolization. Then you free the pacifier plate hopefully on the outside of the LAA. You do a tuck test, you pull a little bit and keep it there for maybe half a minute with a little pull on it to ascertain as good as you can, as well as you can, that the device will not fall out once you release it from the cable. And then you do a dye injection to make sure it's in the right place. You need to have a projection where the two parts are nicely separated to make sure that you see it. And the next thing is to release it. You unscrew it with a left turn. You see the device is now taking its final position, and then you do a final injection again with dye, you can't change anything at this point in time, but just as to document the position. You see there is still some flow going to the LAA, but that will be covered by endocardium, and with this disc outside, the complete closure rate is pretty good with this device, a little higher than with the Watchman device, but it doesn't have to be absolutely completely closed to have its protective effect. Now the clinical data, we all know only the Watchman device, although it came in after the Amplatzer technique, so to speak, has gone to the trouble to do a randomized trial, and we are very grateful for this. The PROTECT AF trial has now published 5-year results, and little bit as a surprise even to me, who I'm an advocate of LA closure, there was a mortality benefit in the late follow-up if you use the Watchman device rather than vitamin K antagonism. So those are all patients who could take vitamin K antagonism because they were randomized to either of the techniques. But you can see that the longer, of course, the follow-up comes, the more problems you had with vitamin K antagonism, because the bleeding rate is there every year. It actually increases as the patients get older, whereas with the Watchman device, you still had some embolic problems. Of course, it's not a 100% protection, but against embolic problems, but there should be no bleeding because you do not need even aspirin in the long-term follow-up of these patients. So there was a mortality benefit, which of course now actually imposes on us to offer every patient LAA closure as the first treatment if they have atrial fibrillation. We should actually tell the patient the best thing is, unless you're going to die anyhow next year, then it's probably not worth it, because in the first, as you can see, in the first 12 months, there was really no advantage of LAA closure. But if you're not going to die next year for some other reason, and you're going to live at least another 4 or 5 years, you should have your LAA closed now and not go on oral anticoagulation. This was with warfarin, and NOACs is maybe another story. I'll come to that in a moment. We're not doing that, and I'll let you know why we're not doing that. I'm actually doing it now. Every patient with atrial fibrillation, I tell them the best thing is if you have your LAA closed. The surgeon does it during any heart surgery that they do, all the better, David. But of course, not everybody needs heart surgery, so they would be a percutaneous closure. Now, of course, you can say that's the Watchman, but how do you know that closing it with an ACP is the same thing? We don't, but we have a 1,000 all-comers registry from Europe, and if we put our outcome of these 1,000 patients on top of this curve, of course, that's not quite legal because it's not a randomization against the other two groups, but you see that the outcome with the ACP is exactly the same in terms of mortality like the outcome with the Watchman. So we can conclude that's an effect rather of the technique than of this particular Watchman device which has done the work. Now, as we know, now we're in the realm of NOACs. We just heard this nice talk of Keith on that, and we may not be any longer competitive with left atrial appendage closure, because now we know that Pixaban, for instance, as one of the NOACs, is doing better than warfarin in terms of prevention of strokes. So are we still competitive? What we did to just test this hypothetically is putting our burn data, which now go back more than 10 years, as you know, of LAA closure, again on top of this curve, and you see that our outcome in terms of prevention or occurrence of embolic events after ACP closure is exactly on the line in keeping congruent to the apixaban curve, looking a little better than the warfarin. So we might still be competitive with NOACs, although there has not been any randomized trial, and there is actually none on the way right now comparing ACP or Watchman to NOACs. And of course, that's just one side of the medal, that's prevention of embolic events. But now we also do not want to cause bleeding, and we know, and we heard that just from Keith, even the most modern NOACs still have an annual bleeding rate. It depends a bit how you define bleeding, of about 2 to even 4% or almost 4% with rivaroxaban in the ROCKET trial. And LAA closure, as I said, needing some anticoagulation for a while afterwards, but after a few months you can actually stop all anticoagulation if you want. Of course, has a big advantage, and every year there will be an accrual of bleeding events in the NOAC group, and there should be hardly any accrual of bleeding events in the LAA closure group. So LAA closure is the better deal than oral anticoagulation. And this is basically also shown here with some indirect comparison. As you can see, NOAC compared to warfarin with the bigatron 110, 150 has a superiority in terms of stroke and systemic embolism prevention. With the higher dose of the bigatron, we know it was even significant. So there's the green color here. And you can see that rivaroxaban has an advantage, not significantly. Apixaban had a significant advantage in this randomized trial. Edoxaban, again, non-significant, but it's a bit better. 60 milligram, 30 milligram, actually worse. That's why this dose, for instance, Switzerland is not even marketed. They only market the 60 milligram dose. And LAA closure in this randomized trial has a significant advantage in terms of stroke prevention, and this is randomized. Now with LAA closure with the Amplatzer, we don't have a randomized study, but we have a huge registry, and we can compare it to the historical dates of all the other randomized trials. And if we do that, adjusted for the CHATS-VASC or CHATS score, you can see that we have also this superiority, significant superiority even in terms of preventing strokes. And if you look at mortality prevention, of course, again, that's kind of not quite legal because it's not a head-to-head comparison. The mortality prevention with the Watchman is actually much, much more conspicuous than any mortality prevention you get with NOACs, always comparing it on the background of warfarin, of vitamin K antagonism. But of course, it's not the same length of follow-up, it's not the same kind of patients, so this sticking out quite favorably is, of course, probably a little bit exaggerated. And cost is maybe an issue, maybe not. Of course, those cost calculations are always a little bit theoretical because you calculate that you save cost if a patient doesn't come in the hospital for some treatment of a bleeding or something. That doesn't necessarily mean that if he hadn't come to the hospital, you would have saved these costs, because the hospital would still be there, it would still be heated in the winter time, the personnel would still be employed. So you don't really save those costs if the patient doesn't come to the hospital, except for disposable material. But nevertheless, this is the way cost is calculated. Now you see that here LAA closure looks extremely favorable. It crosses, if you invest $50,000 US to buy one quality adjusted year of life, if you're willing to do that, this is where it crosses with the cheapest treatment, which is warfarin, vitamin K antagonist, then you will have a cost-efficient therapy. And you see that the bigatron never crosses in this type of calculation with, so it stays even at $100,000 per live year. It's still a bit, still not yet cost efficient. Now these are patients who can take warfarin. Of course, that's the run-of-the-mill atrial fibrillation patient. If you look at patients who cannot take warfarin, and again look at the cost, we know that this was the the population in those trials, ASAP, active, and Averroes. You can see that actually LAA closure here, the blue line, is also cost-effective at the fairly low follow-up range and a fairly low investment that you have to do. So it seems to be not only the best treatment, but in most patients also the most economical. Now, this is a case, which may be unique for our type of approach. We'd like to have this one-stop approach. So, and we have now a series of about 15, not many, but 15 patients with primary prevention LAA closure. Now, what is primary prevention LAA closure? LAA closure is usually done as primary prevention because what you want to prevent is a stroke or a bleeding, if they have anticoagulation instead. Most patients have not had a stroke or a bleeding when you close their LAA. All they have is atrial fibrillation. So you close the LAA for primary prevention in atrial fibrillation to replace oral anticoagulation, which is also primary prevention. Now, primary prevention means they never had atrial fibrillation. So why would you close the LAA if they never had atrial fibrillation? Of course, the surgeons they do that because they're in the heart, or they take out the appendix when they're in the belly, just because they know the appendix will never do any good, but it may do harm. So while I'm there, why don't I take it out? That's primary prevention. Now, we've done that also, which is kind of strange, but probably makes sense. In this patient, for instance, that's one 64-year-old male who has two huge atrial septal defects. You see a double atrial septal defect, and came in for closure of his atrial septal defects. He never had atrial fibrillation in his life, but he's 100% sure to develop it because large atria with this shunt for 60 years, they all go into atrial fibrillation, and now putting in those big devices will maybe just trigger atrial fibrillation. So we know that this patient is not far from atrial fibrillation. So while we go through these holes with a sheet, that the same sheet is used for LAA closure as for these ASD closures. Why not first close the LAA while you're there and then close the ASDs, as we can see here with two different devices. And here you see the motion here with the left atrium here being tainted a little bit by the contrast coming through the lungs. So this is primary prevention. In this particular case, we have a follow-up of echo follow-up at 4 months, and you can see that very nicely the two ASDs being closed here. Can't get this off. Okay, and unfortunately I can't get this thing off here down. But anyhow, you will see that also you have to imagine that also the LAA is nicely closed, shown by this echo there. Sorry to get. Okay. Anyhow. So this is, of course, a bit far-fetched. But now combining things is not a bad thing. About LAA occlusion in our patients, usually patients older than 60 years, we almost always recommend to have a cornea angiogram unless they already had one, because at this age, the screening for cornea angiography is a good thing, for coronary heart disease is a good thing. Every fourth will have a combination with PCI because something is found during this cornea angiogram. PFO closure, if you go through the PFO, you can combine it with left atrial ablation, of course, that makes sense. Other centers have a much higher combination rate. You can combine it with TAVI, ASD closure, mitral clip, other procedures. Now, is that too risky to combine these things? It may not be paid very well if you're on a DRG system, because you only get one DRG for two interventions. If you do them apart, you get twice the same DRG. So it may not be very lucrative, but in terms of risk, it's okay. Here you see all the risk of all our LAA closure. It's not a very safe procedure, in contrast to PFO closure, which never has complications. LAA, working on the outside wall of the left atrium, you have to do transeptal puncture. It's a much more risky procedure. And you can see that the lowest risk in combined was actually combining it with TAVI, which is probably the most reasonable thing. Combining it with mitral clip had quite a high combined complication risk. Combining it with ablation, quite a little bit higher, but of course if you do it in two interventions, you also accumulate the risk to the patient. So you should not get fooled by the fact that you're dealing with two problems at one time. And here is what we'd like to have. This is a one-stop shop procedure. 82-year-old woman, aortic stenosis, LAD stenosis, atrial fibrillation, and the PFO. And in one intervention, you close the left atrial appendage, you close the PFO, you exchange the aortic valve, and you put actually a synergy stent into her LAD. So this is a one-stop shop, and it's certainly doable. It's not, as I said, not very lucrative if you're working on a DRG fixed rate. It's much, because you could actually make 4 interventions out of these and get 4 times the DRG for the same cost, or a little bit, almost the same cost. Now, in terms of oral anticoagulation, and this is the topic of this session, it also makes sense, because if you combine, for instance, a coronary intervention with in patients with atrial fibrillation, you actually should, as we heard, use triple therapy, which is a bad thing. I mean, triple therapy is really a bad thing. You see the bleeding risk if you use a PCI with triple therapy, because the patient has atrial fibrillation. You see the bleeding risk is up here in the blue curve. If you use PCI and close the LAA at the same time, so you just use antiplatelets afterwards, you see that the risk is somewhere here. And if you use PCI and in a patient without atrial fibrillation, with just the normal double platelet antiplatelet therapy that is usual, you see that you're not that far away from LAA closure in a patient with atrial fibrillation. So you bring your patient with atrial fibrillation back to a all risk of MI or bleeding that comes close to a patient without atrial fibrillation. And of course, if you only have LAA closure without PCI, the risk is even a little better. So why aren't we closing all those LAAs? This is the reason. LAA closure is a preventive interventional thing, and we only have one other preventive interventional cardiology intervention, which is PFO closure. Now, PFO closure is the most easy intervention that we have, and LAA closure is one of the more intricate, more dangerous ones. Whereas, of course, therapeutic interventions like ASD closure, TAVI, MitraClip, and PCI, going from very simple to very difficult, but they're all therapeutic. You have to do it. The patient needs it right now, and he's going to be better. A preventive procedure, at best, the patient is as good as he was when he came in, at best. If you have a complication, it's much worse, and it's difficult to explain to him or the family, if a complication occurs, why you did the thing in the first place, if it's a preventive intervention. So what happens here with this complicated and quite dangerous preventive intervention, if there's an LAA closure to do at our center at 5 in the evening, nobody has time, everybody's busy, has other things to do, nobody wants to do it. If you have to put in a TAVI at 5 in the evening, everybody is keen on doing it. Nobody wants to take the risk of doing an intervention with a certain risk for a preventive procedure. So LAA closure is not popular with interventional cardiologists, and it will never be. It will keep its risk, it will keep its preventive approach. So percutaneous closure of the left atrial appendage for stroke prevention and atrial fibrillation is actually something that should be done in every patient with atrial fibrillation rather than anticoagulation, but it will remain an issue with an open issue for the reasons I just alluded to. Thank you.